So thank you to those of us who've joined us online today and to those visiting us later on via our YouTube channel for these presentations. Today we are very lucky to have Rebecca Graham, who's a general adult psychiatrist. She is also not just a psychiatrist, she is a working mother living in home art who has lots of different jobs. She works in the public sector as a general adult psychiatrist as well as privately, and works for Dementia Support Australia. She is very involved and has a passion for education and advocacy, and sits on several Royal Australian and New Zealand College of Psychiatrists committees and groups. She is also a clinical lecturer with the School of Medicine, the UTAS, University of Tasmania School of Medicine, and examines medical student OSCEs. She is the only Tasmanian to be awarded the Psychiatry College Medallion for Excellence during both training and her examinations. She'll talk about the entry to psychiatry training program, requirements of training, and also the broad range of career options and excellent work-life balance that psychiatry can provide. So thank you so much. Over to you, Beck.
Thank you. Thanks for having me. It's lovely to be meeting you all remotely. I'll just share my screen because I've got a bit of a PowerPoint. Is that working okay, Rochelle, on your end?
That looks excellent. Thank you.
Lovely. Okay, so I just started off with my different jobs there that I'm sort of currently all doing at the moment, and that relates to my introduction around having various different hats. And I think that's one of the things that I quite like about psychiatry. You can have quite a varied career simultaneously, and I'll talk a little bit to that today. So I'm a general adult psychiatrist, but I also did subspecialty training in old age psychiatry. So sort of the other title I can use is as a psychogeriatrician as well. So let's see if it will let me click through to the next slide, which it's not doing. Next. There we go. So just a few visual prompts to start off with. Why choose psychiatry? Clearly, I'm very passionate about psychiatry because I went into psychiatry training, and I'm really happy here now as a consultant psychiatrist. One of the things I really love about psychiatry is the breadth of what you can do once you've become a psychiatrist. So starting off from our image on the left there of a mother and a newborn, psychiatry, I think, is really fascinating because we can really go through the whole lifespan of our patients. From perinatal psychiatry, which is when you're looking at mothers and babies, including during pregnancy, right through to the area I more work in, which is older person psychiatry, where we're managing dementia, palliative care, and even terminal care as well. So during my registrar training, I did some placements in our older person psychiatric units. And if our patients there developed dementia and became terminal, as the psychiatrist, we'd actually be managing their palliative care and managing their end-of-life care, which is, both ends of the life spectrum is a really privileged place to be, and everything in between. I'll give a little bit of a plug to perinatal psychiatry because I think it's a really fascinating developing area, which relates, I think, to our second speaker might be someone in O&G today. And it's one area of psychiatry where you can actually do preventative work. So we know now that if we have a look at the attachment and the relationship between mother and baby, which actually starts from conception during pregnancy, and we work on that attachment and that bond between mother and baby, and particularly once baby's born during infancy as well, we can actually do preventative work to look at reducing the risk of baby having mental health problems and illnesses later in life. And this is really important because often in psychiatry, we may see intergenerational trauma, or we might see illnesses sort of get passed down from mother to child throughout the family. And we can actually intervene in that, and we can actually do therapy and work between the dyad of mother and baby to prevent that from being an ongoing thing. So that's a really wonderful area. And attachment is one of our big areas where we know it does increase the risk of mental health problems and conditions later in life. So if you can look at attachment early on, you can prevent a lot of problems later down the line for patients and prevent them actually entering mental health services perhaps. So there's a lot of breadth in age of patients that you can see, but there's also breadth in the type of work you can do as well. So some of the other images I've got there down on the bottom right, you'll see, you may recognize this, which is ECT, electroconvulsive therapy. So that's really more sort of biological science, medicine. It's about chemicals, it's about electricity, it's about dialing things up, and it's very biological, if you like, from that perspective. It's, you know, in a hospital setting, it's usually really unwell patients, and you can specialize, if you like, in ECT, or you can be like me and sort of do a little bit of ECT on the side in addition to your other care. Or we've got the image there of someone doing psychotherapy, so you can go completely the other way as well. And perhaps you decide to become a psychiatrist that specializes in talking therapies. And there are some psychiatrists that go into psychotherapy as a particular subspecialty field. And maybe they actually don't even prescribe medications. All they do is sort of intense talking work with their patients, which may be weekly, several times a week for years or decades. And we know from neuroscience as well and functional imaging that talking therapies can have a similar effect to our biological treatments like medications. And again, that's a really amazing place to be, where you can actually heal patients and look at changing the neurochemistry of patients, you know, based on the language that you're using and your psychotherapeutic techniques. And then we've also got academic psychiatry and research psychiatry. So I've got some colleagues that I went through training with that are doing work in Melbourne at the moment on hallucinogens and PTSD. You might have seen some of the stuff in the media coming out about that. So they're purely research and academic psychiatrists doing research trials, working in laboratories. I've got some friends working on the gut microbiome, looking at crapsules, where they're looking at sort of fecal type agents and things to look at interacting into the gut-brain microbiome. So you can sort of go right down into that field as well if you want to do more lab-based work, or you can do a mixture of both. So a lot of psychiatrists do some clinical work, but they might do some research and academic work on the side as well. So a little bit about the training pathway. This just gives you a bit of a snapshot about it. So it's a 5-year program at the moment, and our current program started in 2012. So that's the most recently updated program, and this was the fellowship pathway that I completed. And the 5 years are broken up into different stages. So in stage 1, that's your basic level of training, and that's really based around adult psychiatry. So looking at people aged 18 to 65. Usually there's a significant hospital component of that. So often your first 6 months is in an inpatient adult ward. And then your second year and third year, stage 2, you're starting to become more proficient. And that's where you get the opportunity to look at some subspecialty areas. So for example, child psychiatry is a mandatory rotation that you need to do. So looking at young people, either 18 years and less or 25 years and less, doing work with really young children, including prepubertal children and their families. There's also consultation liaison, which is another subspecialty area of psychiatry that you must do as part of that part of your training, which is doing psychiatry in the medical wards or the surgical wards. And I guess depending on the area that you're training in, there might be even more subspecialty areas like, for example, oncology-based or transplant-based psychiatry as well. So it can get quite in-depth and quite specific. Throughout stage 2, you can do other sorts of psychiatry as well, though. So you might do some addiction psychiatry or some older age psychiatry or forensic psychiatry, looking at the interaction between psychiatry and the legal field or the criminal justice system. And then your last 2 years is stage 3. So that's when you're really at quite an advanced level of your training. And you may choose, like me, to go into a specific subspecialty area and just work in that for your last 2 years and get extra qualifications, extra certificates in that area. Or you might continue to do more of a general training program. And that's mainly where the bulk of the examinations are sat as well. So all of our assessments are considered a consultant level standard, which is sort of the end of training standard. And you can see the assessments laid out there along the other side of the diagram. And so most of them you do towards the end of your fellowship, so sort of years 4 and years 5. So that's our multiple choice exam, our written exam, which now has been broken into 2 components, an essay and also sort of a short written vignette type exam. So you can sit them and study for them separately if you want to, or you can decide to sit them back to back together. And our OSCE exam as well, which is our clinical focused exam, which is usually done in person, but with COVID at the moment, they are doing that with an online option, but I suspect it will hopefully go back to face-to-face at some point. We also do some really interesting other summative assessments, so formally assessed assessments external to your local area of training, which is your psychotherapy written case and your scholarly project. So those are often things you're starting off early in training, but you don't have to have them finished until towards the end. The written case is where you actually give therapy, psychotherapy, to a patient every week for an hour for 6 to 12 months. And then you write up that person's case in a case report, and then that's what gets assessed. So it's really fascinating, but also really helpful for your training and for your ability to use those skills later on when you're finished. And then the scholarly project is a research-based project, but you can get an exemption for that. So if part of your medical student training or a past life, you've done some research or had an article published, for example, or did some honours, then you can get that often accepted as an exemption, which means that you don't even have to do that assessment unless you want to do some research as part of your training. We also have some sort of more bedside, if you like, assessments that are just assessed locally. So that's the WBAs and the EPAs referencing there, and they're just looking at different competencies that you're expected to be able to tick off and pass as you go through your training. I'll just finish up talking about the training pathway before I talk about entry requirements with another aspect of the psychiatric training pathway, which I think is really special to psychiatry and is another area that I think is a real strength and a real interest in doing psychiatry as training. So we have a relationship as trainees, as registrars, accredited registrars, with our supervisors, with our consultants, which is quite different, I think, to a lot of the other training programs. So every 6 months, you'll have your primary supervisor, and part of the training requirement is to have something called supervision, which means you get an hour a week or 2 hours a week if you're in your first year, one-on-one, sitting down with your consultant, and it's just your time. It's not a time to get interrupted. It's not a time to do ward jobs. It's not a time necessarily to talk about clinical work unless this is what you want to use your time for. It's your time with your supervisor to decide to use it how you like. And it's a really lovely ability to be able to reflect and grow on yourself as a person and how you're developing as a psychiatrist, and it's quite special. And previously, one of the other hats I wore during training was on the AMA Council of Doctors in Training, presenting the psychiatry training group, and sitting sort of in that, around that table in that room with the physician rep or the O&G rep or the GP rep. Really a lot of the other people there were saying that they envy the ability that we have as psychiatry trainees to have this special relationship and this supervision that you don't necessarily get in other training programs. And so we really pride ourselves on that, and it's very much emphasised and is a non-negotiable important part of training that you get your whole way through in every rotation. So just finishing up with the entry requirements, I would suggest it's probably not as onerous to get into psychiatry as it is some other training programs. We don't think you need to be a psychiatrist before you join. We will make you a psychiatrist, and we really often appreciate people having a wide, varied background of experiences within life or within other careers or within medicine before they join psychiatry as well, because being a good psychiatrist it's about life, and psychiatry is about life, and it's about well-being. And so all of those other experiences are actually strengths that we will see as strengths if you apply for the psychiatry training program. So we don't expect you to have necessarily done lots of terms in psychiatry, or to have done a research project in psychiatry, or to done different courses in psychiatry before you apply for the program. And that's reflected in the sort of mandatory entry requirements. So it's quite basic. You just have to have completed your medical degree, number one. Number two, you have to have general registration. And number three, you have to have done, they say, 12 months of general medicine. But actually internship, in my experience, counts as that as well. So we will make you a good psychiatrist, but you need to be a good doctor in order to start psychiatry training, because you won't necessarily get the same exposure to general medicine once you start psychiatry training. So that's a real emphasis as well, is to make sure that your general medical skills are up to scratch before you look at entering psychiatry training. And so it does mean too that it can sort of shorten that pathway, I guess, from a career perspective, if it's important for you to specialise within a shorter time frame, maybe for work-life balance reasons. So I actually entered psychiatry straight from my internship. And then was able to get through fairly swiftly. So we have an undergraduate medicine program here. So I was quite lucky to become a consultant before I was 30, which is not necessarily available with a lot of other training programs. So just coming on then, that's a good segue to my journey. So as I've just said, I entered psychiatry fairly early on. I thought if I offend anybody, if I start the program and I don't like it, it's just going to be the other psychiatrist. So I might as well give it a try. And I found it a really fascinating, interesting training program. I managed to do quite well, and I did win that college award, despite the fact that I was the only person in Tasmania training at my level. So I sat all my exams on my own. And I was the first trainee down here to do the new program. So a lot of the exams are sort of quite new as well. And I was trying to figure out what they sort of wanted from me. And then I entered private practice initially after I finished. So I had my fellowship in May and sort of June. And then by July, I had my first baby. And so the image there is of me being back at work as an early career psychiatrist. I have a stay-at-home dad who looks after my son. And the flexibility of psychiatry really helped there. So I could actually figure out, what hours I wanted to do, what patients I wanted to see. And that flexibility is in training as well. So we do part-time training, and it can work quite well from a work-life balance, both during training as well as when you're a consultant. And I was able to continue breastfeeding, which was really important to me. So that's an image of my freezer because I was pumping sort of at work, and I was able to organise that and structure that day quite well. So since then, I've gone back into public practice as well as a bit of private, and I do some of my old age work as well, which really suits me. So I'd really emphasise the flexibility of psychiatry. I think it really lends itself quite well in that way, and also assists with work-life balance. So just to finish off with some links, I would quite recommend the Psychiatry Interest Forum. So that's available to medical students and junior doctors, and you can look on the website. Pre-COVID times, there was actually a lot of availability for funding. So some med students a few years ago that I met got flown to Hong Kong to go to our annual meeting and attend their functions and things there as well. There's a lot of money that the government put into psychiatry training and getting students into psychiatry and junior doctors, because we are an area of need. So you will find work if you go into psychiatry. And there's certainly a lot of money put into additional training programs around the country, training places as well. So I'd recommend sort of the college website and having a bit of a look around there. So I'll finish up there. I might stop sharing my screen in case I can see anybody's faces that want to ask questions before my time finishes up and we have the next speaker.
Thank you so much for Beck. That was fascinating. I just got a couple of questions. I'll just sort of run them from the chat if that's okay. And then if anyone else wants to unmute and ask, that's absolutely fine as well. The first one, you sort of mentioned employment opportunities right at the end there. That's often one that comes up as sort of a question mark for a lot of our students in the current sort of climate. So does that mean they sort of will be able to really be looking forward quite positively to being able to work where and how and when they want if they sort of get through the program?
Yes, I certainly would say that. So the NNTAM, which is the big sort of national government body that looks at medical workforce planning, has very much identified psychiatry as the big area of need across the country. I mean, it's partly a regional thing in that if you're in a regional area, obviously there's sort of less specialists than in the cities. But even with that, there's still not enough psychiatrists. So there's a lot of work. I would say that depending on, how specific you are and where you want to work, you may find that you have to wait for a certain job. So, for example, as an old age psychiatrist, there's sort of 3 or 4 of them in the whole of Tasmania. So
wow.
If I was hanging out for a full-time position in public in that particular area, I may be waiting a while. But there's definitely work. And particularly with COVID and the increase in telehealth, there is a lot of work in private psychiatry as well, or you could work salaried for a company that does telehealth if you want that security. And then you can work from home potentially too. So you would definitely get work. I guess it depends on where you want to live and what specific area you want to work in as to the exact ability for you to get the exact job that you want, but you definitely won't be without work.
No, that's amazing. And because the other thing that I found really interesting was this kind of idea that there's all this actual kind of research and rigorous academia involved in psychiatry. Because from my sort of memory of undergrad sort of medicine, and even sort of postgrad when I did my intern position as a sort of psychiatry intern, it didn't necessarily feel like that. But I'm guessing that might also be that there has been huge sort of gains in some of that research. You mentioned neurochemistry. How do we know how to change that? How we've effectively changed that soup? What sort of markers do we use?
Oh, I guess this is less sophisticated an area I can talk on because I'm not an academic or research psychiatrist. And I would probably suggest that the area we're moving to more is around circuitry as well, rather than actually necessarily looking at neurochemistry. That's probably even a little bit, I would maybe a little bit too basic, like moving forward and looking at actual, brain circuits and function, and rather than necessarily looking at how much serotonin have you got or how much dopamine have you got. But one of the advances even in my area is functional imaging and PET scanning, looking at, for example, the diagnosis of neurodegenerative conditions. So I can do like glucose uptake scans and things to go, does this person have a dementia or not? Do they have this type of dementia or that type of dementia? And that's the sort of area where we know, for example, for psychotherapy, you could have someone with a depression and they might have reduced metabolism in, say, the frontal lobes of their brain, and then you can do psychotherapy with them and you actually see an increase. So you can see that those markers that we associate with illness are reducing. And we can actually measure that, for example, for therapy, like we would do if we give them an antidepressant and then rescan them and say, oh, look, they've got, activation in these parts of their brain that were reduced before in the context of their depression.
That's amazing. And I'm guessing that might, I can talk about this for ages, actually. I find this really interesting. I'm doing radiology, and that kind of process of functional MR and sort of working would be good, but that's for a side topic. I can't see any other questions here in the chat. Oh, yeah, please. I'll mute myself.
Yes. My question was, so at the moment, it is quite possible to get on a training program as a PGY2 without any research or extensive psychiatry experience. Hello?
Sorry, I can't hear you very well. Is there any other noise around you, or is anyone else not muted?
I think it may be a background noise. So far, I think I'm following you. You were talking about it being fairly easy to get on PGY2. I can see how I go with trying to get the rest of your question.
Try again, yes, sir.
Oh, lovely.
Do you want to type your question in the chat?
Yeah,
then I can.
Yeah, we do have a question in the chat, so I can see that there. So do you anticipate the situation being the same in 3 or 4 years' time? From the perspective of getting on the program, I would probably suggest yes. I think there is an increase in people wanting to get on the program in general over time. And I know that there's concerns in amongst medical students about this sort of tsunami of students, which was, something that was talked about when I went through, which was sort of over 10 years ago now. But I would still say that certainly locally, the people that I know that want to get on have gotten on. And I think that's about, I don't know if it's the same in Queensland, but in Tasmania, in a smaller area, sometimes it's not necessarily about what you know, but who you know as well. So I think reaching out to the local director of training or the deputy director of training. So some of the larger states like Queensland would have different subzones of training and different people that sort of run the different training programs, and letting them know maybe, when you're doing your psychiatry rotation or when you're getting towards the end of your medical school years, I'm interested in doing psychiatry, and making those links early. I think that goes a long way as well to increasing your chances of getting on the program. But I certainly don't think we're churning out enough psychiatrists that we're suddenly going to fill the demand in the next 3 or 4 years. That would be my suggestion.
Excellent. Oh, that's really good. Thank you.
I had a question, actually. Yes. Great presentation, by the way, Rebecca. It was really interesting. I wanted to ask how important keeping up with the latest research in psychiatry was, and how you went about keeping up with it while you were practicing and so on.
Yeah, I think that's a really good question. I think as all doctors, we should always be keeping abreast with developments in the areas with which we're working, and as students as well. Once you finish your specialty training, there's a requirement through APRA that you guys might know to do continuing professional development. So that's the requirement with my college as well. And so I have to sort of show evidence as well that I'm keeping abreast of things. So usually one of the ways I like to do it, which again is a bit trickier with COVID, but we were quite lucky we managed to get our annual meeting this year down in Hobart in between various shutdowns, is attending the conferences and attending annual meetings. I find that a really engaging way to learn and keep abreast of things, and then I can sort of follow up different research or things that I find interesting from there, later on. Obviously, journals is somewhere where you can look to as well. So we have two journals that are Australian-based psychiatry journals. So we have Australasian Psychiatry and the Royal Australian New Zealand College of Psychiatry, the RNZCP journal as well. And that's even a place that you can look to as medical students, particularly Australasian Psychiatry. It's not uncommon for them to publish something from medical students as well, if you're interested in getting into research. And then I guess the other thing is, if it's really something you're interested in, probably pursuing research and people that are doing research, and that may be in a centre different to where you are. So in Tasmania, we do have a little bit of research that happens with the Menzies Institute around dementia. But some of these other big projects I was talking about, like the neuroscience stuff, the neuropsychiatry stuff, which is its own field, really developing now, the gut microbiome stuff, the hallucinogen, sort of more sexy stuff, mainly comes out of Melbourne. So probably Melbourne and Sydney, where you can get sort of joint academic and research posts as well as trainees. So maybe consider moving if it's something that's really a fiery passion for you, perhaps as well.
Right. Well, I am from Sydney, so I suppose it'd be good for,
okay.
my mum would be very happy if I did move back. Yeah. So then what kind of evidence would you need to provide, like, to show that you're keeping up with the research? And
it's not too onerous. I guess the emphasis is really on you doing due diligence yourself. I mean, you can get audited, where if you say I did X amount of hours researching frontotemporal dementia, and you could get audited where they go, we'll prove it. What did you read and what did you look at and who did you talk to? So I guess that's one aspect of it. For me, it's about attaching it to my clinical practice as well. So, for example, if I have a case coming through the door to do with clozapine or something, and a side effect or a non-response, which is where I'm working at the moment, which is one of our more complex medications, I'll actually go and look at the literature and have a look at what the most up-to-date articles are. I might do some PubMed searches and things that you guys would be learning all about. And then bring that back to my clinical work. And talking with colleagues as well, and peer review is really important too. So sharing that knowledge around with other specialists.
brilliant. Oh, that's great. Thanks so much.
Divya's actually been able to join us now, which is
great.
brilliant. So that's my bad. So thank you so much. I'm so pleased that I can now introduce Divya. So thank you. If there's any other questions for Beck, please let me know, and I can maybe email them or sort of get back to you if Beck's happy for that. But for now, thank you so much.
Thank you.
I'm so excited to introduce Divya. Sorry, Divya, I was getting a bit panicky, and I'm so excited to see you. Let me just open up my introduction. And I will say that Divya is a wonderful fourth-year registrar in ONG, working at the Mater Mothers Hospital. She initially started out her life career aim to be a vet, but after doing her undergraduate degree and biomedical sciences in Canada, decided that she really would prefer to work with humans, and so completed her MBBS at UQ as an international student. Which is sort of good news for some of you guys who are sort of looking at wanting to stay. She delivered her first baby during her ONG rotation at the Royal and realised that was her passion, and managed to get onto the training program, and is now currently in her fourth year. Her special interest is medical education, paediatric as well as adolescent gynaecology, leadership in sort of medical field, and development of policy. She is also heavily involved in the Zonta Club of Brisbane East, and is a passionate advocate for women's issues, including DV. In her spare time, which she does have a little bit of, she loves learning the art of Japanese flower arrangement, cooking, and running around after her 1-year-old son and her cavoodle puppy. So Thank you so much, Divya, for joining us today, and I will hand over to you.
Hi, everyone. My name's Divya. I'm really sorry that I'm late to the webinar, guys. I got a little bit caught up with my son had to run to the daycare, hence why I'm in the car. So I apologize for that. That wasn't the plan, but we'll just make do as we are. And thank you for being so patient. And I apologize again. I'm really glad to be here. I've known Rochelle for a while, and I thought the actual series that you guys have is really interesting. It's not something I had as a medical student, and I think I would have really appreciated that, just to hear from people of different specialties and kind of get an idea. I think when you start med school, you're a little bit doe-eyed, you're definitely eager, and you're keen, and I think that that's a wonderful feeling. I guess what I would sort of suggest to you all is to try and maintain that feeling for as long as you can, and if you can, for the rest of your life, regardless of what you choose to practice in. I think it's really important that as med students, you guys stay really open-minded about your options, because I think very early on you might know what you want to do, but it will often change. And I think even though I knew right away I wanted to do O&G, that wasn't the straight and narrow path for me. It took a really long time to get there. And I think that's it's worth mentioning that it's okay if you're the kind of person that says, look, I'm not really sure where I see myself, or I definitely see myself in medicine, but I'm not really sure where I see myself down the line in medicine. In fact, like, there are many careers in medicine. It's not just isolated to clinical practice. And I think that you should be open to that idea, because you'll find that throughout your life, those choices may change, and your interests may change. So I think it's important to be open to that. And that's why I think that when you do rotations, you'll learn very quickly that there is no rotation that is wasted time or wasted learning. I think that people have the opportunity to learn from every experience that they do. And sometimes sometimes I remember doing rotations that I wasn't excited about and definitely not interested in, but being in them, I thought, just throw yourself into it, learn as much as you can. You never know what you're going to take away from it. And I was lucky enough that each of those opportunities became something that was interesting. And I think that if you make the best of every opportunity that's given to you, you're more likely to find something valuable that you can take away from it. I think that sometimes in med school, it can get a bit overwhelming, because you think about all the content that you need to learn, all the work that you need to do, and you go, why am I doing this? And I think that once you get to the clinical years, that kind of seals the deal for a lot of people. They really appreciate why they need to put the effort into learning some of the background, as well as the knowledge base, in order to improve, how they are clinically and how they are with patients. And that was kind of what sealed the deal for me. As soon as I got into clinical years, I said, oh, now I understand why I'm doing it. I get it now, and I'm definitely a clinician by heart. I'm definitely a hospitalist. I can't really see myself anywhere but a hospital, doing acute things. And that kind of reaffirmed to me who I was and who I want to be. And that's kind of important, and that you're open to the idea that these things evolve. In terms of, I guess, I don't have much more advice or anything else really to add. I'm happy to answer questions, because I assume this was more like a Q&A. But I think that when you're doing these rotations, I think it's also worth writing things down. So I don't mean necessarily like, I'm writing down clinical things or clinical learnings, but sort of reflections. I think it's really, really underrated, actually making reflections on what you're learning. And it's something that I started doing this year. So you can imagine, as a 4th-year registrar in a 6-year training program, I wasn't really writing things down until this year. And reflections can include things like, I did this today with this person, and I learned this, and I felt really proud that I did this right. I think it's really important to recognize these little wins, but also to recognize there's heaps of room for improvement. So it's not going to be a journal full of everything you've done badly. It can be a journal of things you've done well, things that you've learned. And your reflections don't all have to be clinical in nature. They can be reflections about yourself. I felt really strongly when that patient, let me know that they used illicit drugs in pregnancy. And then you can go and question that and go, was there some elements of countertransference? Is that something I need to work on? Why did I feel that way? Is that fair to that patient? And I think that's really important, because if you keep addressing those concerns, you're just going to make yourself a better clinician. Sometimes you feel you surround yourself with people that are like you. And most of the time that's the case, because people like to be around people like them. People like to have all their own beliefs reaffirmed. And that's okay. But sometimes it's really good to surround yourselves around people that aren't like you, that make you feel a little bit uncomfortable, that do things differently to you, so that you can then question, why does this make me feel uncomfortable? Why did the way that consultant spoke to that registrar not something I like, and maybe not something I'm going to become as a consultant? Or how, like, I thought that interaction between that consultant and that patient was wonderful. How lovely, and how, what a great way to break bad news to that patient. It was sensitive and empathetic, and that's something I want to emulate in my practice. So these are all things that you can write down in your book, because there will be circumstance, whether you like it or not, you will be around people that are not like you, that make you feel uncomfortable, or in places where you feel like, look, I don't fit in. And I think it's important that just having that book of reflections that's to yourself is valuable, because you can always revisit those pages again and look back when you're in a better state of mind. So for example, if you're upset, you can write it down, and it's, you know, say, I wasn't appreciative that patient yelled at me, that I was late, even though I was really trying. And because that'll happen, things like that will happen, where patients, you'll do whatever you can and patients won't be happy. And you know, you write it down, you'll come back another time and you go, well, it's been a year since that incident, and now I know how to handle people who get angry or upset. I know how to de-escalate. I know how to, so these are things that I found really, really valuable, just writing it down so that I could go back and look at it from time and time again. Anyways, there are a few questions, so I'm happy to answer some of them. Sorry, Rochelle, I'm sorry, my love, you're muted. I can't hear you. Yep.
You are right, I was. Do you want me to just ask you those questions?
Sure.
So,
yeah.
yep. Okay. So Jenny's got a few. You've got a few people that are very interested in O&G. First one is that what sort of entry level do you and others generally get onto the program at? So PGY ?
Yeah. So look, typically speaking, people get on after at least one to 2 years of PHOing. So intern year, JHO, SHO, PHO, and then on the program. I think I did an intern year, did 2 months of JHOing, stepped up to SHOing, and then did a PHO in O&G. So it was intern year, couple months of JHOing, SHO and O&G, PHO and O&G, registrar on O&G. So I kind of beeline for O&G. I don't think there's anything wrong if you're thinking about multiple specialties to take a little bit more time, okay? I think it's really important, and sometimes I regret not doing a pediatric rotation, not doing a mental health rotation, because these are huge components of obstetrics and gynecology. You know, perinatal mental health is one of the leading causes of death among postpartum women. So it's really important that you're exposed to things that, you know, and there's nothing wrong with taking a little bit of extra time to do that. Typically speaking, it's around PGY 4. You get about 3 applications to the program, so there is a limit, and so you want to make it count. You want to make sure that your application is robust in nature, it has adequate points that make you think you're competitive, and you've had the opportunity to do things like the pre-vocational program, which RANSCOG offers, that just gives you more points. It is highly and strongly recommended that you have unaccredited registrar year. So this is essential. And I think it gives you a taste of what being a reg is like before you decide that's definitely what you want to do for the next 6 years.
And once you're on the program, Jenny's, one of our students has a bit of concern about the actual experience of the program. She said she's heard some bad things about the nature of the program. She used the word sort of toxic, passive aggressive type stuff. Now, I know that can be a problem on many, many programs, and it comes back down to what you were talking about in terms of consultant and registrar interaction in hospitals. And sometimes that's top heavy. It's because the executive have no money and there's pressure on everyone sort of down the field. But as I guess as a college, do you think that's a problem for O&G? And if it is, are they doing things to address it?
Yeah, look, I mean, everything I'm saying here is my individual opinion, okay? So I'm not affiliated with the college in the sense that I'm a representative of the college. I am in the sense that I'm a trainee. But I guess what I see where Jenny's coming from, and a lot of the surgical programs unfortunately carry that label, particularly in the last couple of years. And I think that's a good and a bad thing. So the reason I think that that's a bad thing is because there's lots of elements of our culture that's changing, okay? I think it's a good thing because I reckon there are elements of toxicity in every program and they've existed, but now we have a label for them. Now we have avenues to recognize toxic work cultures and bullying and call it out. We have avenues like employment assistance programs, colleges that make statements about bullying and harassment and set up things like trainee support centers within their college, which Branscog has, which you can call. And I think that's really, it's actually led to all these beautiful things that basically say, no, we're putting a foot down on this. We're not letting this be a recurring theme. It's not going to be something hiding and lurking in our history in the past. We're not going to let trainees get so burnt out that they commit suicide or things like that. And I think that it's really coming to a head and to a light. Is it the best it can be? Absolutely not. Absolutely not. There's so much work in that area, and I think that it's great to see more colleges take stance. I think that as a trainee, you need to be your own advocate. Okay, you cannot, regardless of what college you choose, rely on the college to look out for you constantly. They will to some degree, but they don't know what you're going through. They don't know what's happening. And, there are situations where you fear being reprimanded, where you fear the outcomes of your career if you speak up. And in those scenarios, you may need to navigate very carefully and decide, look, this is not the hospital for me. I'm going to relocate to a different hospital. I'm going to start again. I think that if you feel like an environment is toxic, there are ways out of it. It doesn't necessarily mean that you're stuck there. And that's what you need to know. No one expects you to sacrifice so much that you sacrifice your mental health and well-being, because we all know that if you can't look after yourself, you can't look after patients. It's really quite simple. And that's kind of a high priority. So I appreciate what you're saying about, sometimes toxic work culture. It does exist, unfortunately. Not everyone's immune to it. And you will probably experience it regardless of any program you go to or any hospital. But I think you need to find your allies. So there will always be allies in every department or within other departments, mentors. Oftentimes individual hospitals have peer support programs. Like when I worked at Caboolture, there was peer support programs. Every hospital and Queensland Health has an employee assistance program. So you can seek out psychologist support and also, which might give you some strategies on how to cope or how to approach the situation. So just don't feel alone. Things are getting better. Things have a long way to go. And for what it's worth, I think it's really important. This is something a consultant said to me once, because when I was a junior house officer, I said, I work with this doctor and he's not particularly nice. In fact, he's really mean and he's quite demoralizing when he speaks to me, but he's an amazing surgeon. He's an amazing surgeon. And then he said to me, well, Divya, he's not a good doctor. And I said, no. If I had a cancer, if I had this, I'd want him to cut it out. Like he's and he said, no, but he's not a good doctor. A good doctor is someone that is more than just good clinically and academically and procedurally. They're also good at people skills. They're also empathetic. And you're not born with all these skills, but you can certainly learn them. So I think that, it's important to start shifting our mindset into what good doctors look like and what good mentors look like. And there are many of them out there. So for every toxic doctor, I'd say there's probably 2 or 3 really good ones. Okay, so I think it's important that if you're ever in those experiences that you reach out for help to those people. And I think I'd be dishonest and foolish to say that, some toxic environments don't exist at all, or toxic work culture doesn't exist at all. That's not true. That's dishonest. But it takes a community to perpetuate that, and it takes only a few people to stop that. So, there are always lots of people in a hospital environment and in a college environment that are very pro trainee, pro support, pro preserving mental health.
That's awesome. Thanks. I'm not muted. I think so. Just to sort of summarize the last couple of points that Jenny has here, I think she's mentioned rural training as being sort of something that's popping up in some of her research. Have you done rural? And if you haven't, I guess, what is your understanding of what the requirements are?
Yeah, so I actually did a rural term in JHO year. I was in Gundawindi, and then 2 of my training years for Ranscog were in Toowoomba. So I've done a fair amount of rural time. It's fantastic. And if you think that you will ever be a specialist rurally, you are going to check massive points for the college because they're desperately needed. The beautiful thing about rural practice is that you need to be really clinically minded. You know, when I was out of Gundy, I mean, they have a CT scanner now, but they didn't before. I had to clinically diagnose appendicitis, okay? And sometimes it took a day for my full blood count and my CRP to come back. So it was all clinical. And there's a real beauty in that, because that's what you're trained to do in med school. You know, that's what you're trained to do. You're trained to be a clinical brain, and it isn't, investigations are at your fingertips constantly. And so you get to use that skill. And the other thing I found rurally is that people are incredibly appreciative of what you do. You are not just another cog in the wheel. You are really appreciated. You are providing a service that they would have to drive 4 hours for normally. And for you to, you know, help a woman who's had a prolapse by providing a vaginal hysterectomy or something really simple so that she can recover in her local rural hospital, see her family during recovery, is monumental for them. And I think that that's really rewarding if you choose to work rurally. And I think that the people and the community are incredibly hospitable. And there's been no other place where I've worked where, you know, patients give you gifts, like they give me gifts in the city, but in the sense that like they give you really sweet things, you know, like, oh, I grew these tomatoes in my garden. And like, it's just a really thoughtful kind of community that you're in. And then you feel really valued and you feel like you're actually making a positive difference. So if you have the opportunity to go rural, by all means do it. I think it's fantastic. If you want to practice rurally, good on you. It's a fantastic environment. I'm still trying to convince my husband to go rural. So I'm working on it. But I think that it's a great way to work in a multidisciplinary team. It's a great way to support our rural communities, given how much they do for us. And yeah, I think that you really become a better doctor by going rural.
That's great. And one more thing, I think Jen's got a question about being a GP, but we're going to have some GP stuff later on. So I think that might be something that we look at in a future webinar. But certainly the last thing is it is competitive. And I know there are people that I know that have been able to get onto ONG. What would you advise is the best way for sort of a current student / intern to make themselves as competitive as possible?
Okay, so it is competitive. Every program is competitive, unfortunately, and that's just the nature of the program. Sorry, I'm changing up my camera because it's getting really hot in here. And can you guys still hear me? Yes. Okay. So I think one thing that I would do is to actually reflect on what the requirements of the program are. So every program on their website will have their entry requirements. So what I did was basically go to the page, print it out, start circling all the things that they expect that I didn't have. Okay. So research, first author paper, maybe a presentation at a conference. And then I started to lay out how am I going to get there? And when am I going to apply? So am I going to apply this year? Will I have achieved everything in the application, or, you know, do I need 2 years to do that? The other thing I think is really important is being authentic to who you are. Okay. I think that sometimes we get caught up in this rat race and we panic and we think, oh my God, so-and-so is doing this and this and this, so I need to do this and this and this, if only to be just as good or better. Okay. I don't think that's the case. All right. So there are a lot of times where people were like, you know, like a lot of times where you look at other people, I know I did this in med school. Oh my God, so-and-so's playing sport, plus they're on UQ Medical Society, plus they're on, and they sing and dance, and they, you know, oh my God, they're just so amazing. How come, you know, I'm not an amazing dancer? How come maybe I need to invest in these skills? But I think it's about being authentic to who you are. So if you know that you're really, your skills lie in something else, you know, then you should look into those things and sort of try and excel in those areas. I think this is important because a lot of people sign up to do research they're not interested in. And I just don't think that's okay. First of all, it's your time. You should value your time. The more you practice in medicine, the more you realize that your currency will never be money. It'll be time. It doesn't feel that way as a poor medical student. It doesn't. But I can guarantee you that once you start making an income, you will be fine financially. But what you'll find is I don't have time. I don't have time for anything. I don't have time for my family, my friends. And this is where time becomes a really valuable asset to you. So treat it as a valuable asset from now. Start now and just recognize that your time is valuable. What you invest in is important. And yes, you want dividends out of the things you invest in, but also do things that are genuinely you. So if you love research on a very molecular level, you're a geneticist at heart, well, then do that. Okay. I don't expect you to do public health research. If you're like, no, I can't be a lab rat. That is not who I am. I need to be clinical, then fine, do clinical research. There's heaps of clinical research where you're recruiting patients, etc. So I think that it's really important that you sort of find those avenues that you can be authentic to who you are. You know, if you're someone that enjoys leadership, join UQMS, by all means, take on a leadership position. If you're someone like, oh my God, I can't even stand the idea of running a portfolio with, 30 representatives, that's not who I am, then fine, pick something else that's a little bit who you are. I love volunteering in the community, volunteer at a soup kitchen. So I think that my attitude is, yes, it's competitive, but you will shine more if you choose things that fit you, that fit your personality. And I think that interview committees see that. There are lots of people that, are amazing athletes and are on national teams and do amazing things, and that's fantastic. That's who they've been. But if you've never been on a national team, no one expects you to go sign up today, okay? In fact, you probably won't qualify because you've never been that level of athleticism. But I think that you can recognize that you have other strengths. So definitely be competitive, but be competitive in the way that your strengths shine. And don't look at competition and be intimidated. And it's easy to say that and much harder to do because we've all been there. I've been there. I still do it. But I think that you need to sort of decide, who am I as a person? What am I willing to compromise and sacrifice to get there? And is that too much of a sacrifice? Or is that enough? And where it becomes too much is when you do things that aren't authentically you. Oh, I think you're muted again.
Myself, here we go. Sorry, I couldn't unmute. I'm not now, but no, thank you. That was amazing. I actually think that is probably a really good message for all medical students, and probably good for life too. Like, it probably fit regardless of whatever course you want to apply for, training program you want to go down towards. If you're not doing something that fits well with you, then you won't do it as well as you'd like to. And I guess that's where a lot of burnout and things like that lie too, when you haven't had that sort of balance and understanding and insight into your own abilities and skills. So hopefully everyone has taken away heaps from that. Thank you so much for that, Divya, and that was brilliant. That was exactly what we want. So if anyone else has any other questions for Divya, then you can sort of get in touch with me, and maybe Divya might be able to email me back if there's any other concerns or questions. But other than that, I think we better let you go, and thank you all so much for being here today.
Thank you so much, guys. And I'm sorry I was late. But
No
yeah,
worries.
feel free to email Rochelle. And if you guys have any questions, I'm happy for her to pass on my email. Happy to connect with the people that want to do O&G as well, if you have further questions.
Excellent. Thank you.
Take care.
Thanks for that, Bindi. Should we stop the recording now?